We did the majority of our cardiology yesterday. But as I said, I didn't want to completely inundate you guys because sometimes you do need a break from just a massive info dump. So conveniently, we were talking about this a little while ago, there's conduction blocks. There are a number of different blocks that can start in different areas. The majority of blocks that we talk about are from the AV node, which gives you your first, second, and third types. Then you can also have disturbances in the conduction through the ventricles and pre-excitation syndrome. So first degree heart block is entirely dependent upon what the underlying rhythm is. Again, like we talked about this when it's PEA or any rhythm that has like a PAC or PVCs or something to that effect. So your underlying rhythm, right, for example, right here, this is a sinus rhythm. However, you'll see when you look for your P waves, they're not married to the QRS as closely, right? They're dating, but they're still talking to other people, kind of. Like this is, there's more than one large box between the QRS complex and the P wave. So if you look here, right here at this complex, here's your QRS, here's one big box, and here's your P wave. So that is indicative of a first degree heart block. So basically, there is an extremely long pause at the AV node that's creating this extremely long pause. So most of the time it's kind of a non-issue. However, if you have a patient who has a first degree heart block in the presence of a syncopal episode, there is a possibility that the first degree heart block has progressed to a ventricular standstill. So I was reading another textbook, was a more advanced cardiology book. This talks about that it couldn't be an intermittent higher degree block, the first degree. And a lot of times you'll notice that patients who have, the hospital and like cardiologists will opt to give patients with first degree heart blocks pacemakers, because what happens is all of a sudden it turns out that this P wave cannot conduct to the AV node, and then the AV node and the ventricles do not respond at all. So you just end up with this line of asystole. The patient has a syncopal episode, and if that conduction between the atria and the ventricles is not restored, it can continue on to arrest, to cardiac arrest. So it's most of the time it's a inconclusive finding that we kind of note. We tell the hospital and they're like, that's nice, no one cares. But if you have it in the presence of syncope, you need to make sure that you carefully monitor this patient, because they may actually progress to a much more significant heart block, which is kind of wild because we're sort of taught that it's no big deal. We talked about this already. So nothing really new here in terms of information. It can happen because of increased vagal tone. It can be like a normal variation, just based on how someone's heart conducts. You can have one that's sort of borderline first degree heart block, which means it's like close to that that big box, but it's not quite there. But you need to make sure that when you do talk about it, you do identify the underlying rhythm. So when we talked about, or you see on the quiz, the second degree type 1 or type 2. So when you have this is like its own rhythm. Again, you'll see that the QRS is usually relatively tight, but there's something wrong with the way that the atrias are communicating to the ventricles, okay? When it comes to the second degree type 1, we call it the going, gone. I don't know where the picture went. Picture's missing. I'll find you guys another picture in a second. It's the going, gone. So you have Here you go. So if you look at this EKG here, the P wave is close to the QRS, and then it's a little further away from the QRS, and then a little further away from the QRS, and then the QRS is dropped. So it's sort of like we're dating, we're fighting, I'm packing my things, we broke up. Then they make up, right? So then the P wave usually conducts a lot closer to the QRS the next rhythm. So there's usually a relatively regular kind of pattern that you see with the going, gone. Sometimes it's hard to see because the distance between the P wave and the QRS doesn't lengthen significantly. If you do have a patient who has a second degree type 1 block, and it's starting to compromise their cardiac output, you're going to treat them with atropine or pacing. But for the most part, it's usually associated with increased vagal tone or an MI. Electrolyte imbalances sometimes cause it, but for the most part, it's conducting at a rate where it is sufficient to maintain life. I guess we'll use that. Also, if you see the term winky back, it's the same thing as a second degree type 1. The phrase Mobitz type 1 or Mobitz type 2 is also this equivalent to a second degree type 1 or type 2 block. We, I guess, decided that we aren't going to give Mobitz his time of day anymore. We're going to just call it second degree type 1. Now, second degree type 2, if you look back at the quiz as well, that picture is a pretty good tracing of a second degree type 2. This is where it is. This right here is a second degree type 1. You see, it's getting a little longer, dropped. Getting a little longer, dropped. Pictures got mixed up apparently. So the second degree type 2 is, if you look at the quiz, the question about the 56-year-old male, the P wave, the PR interval, right, the distance between the P and the QRS remains constant, but a dropped beat does happen. Okay. Second degree type 2 is considered a little bit more serious than a type 1. Most of the time it is associated pretty strictly with an MI. Again, electrolytes can play a part in this, but as long as the patient is hemodynamically stable, there's really not a lot that you're going to do for it other than note and tell the hospital. This might be a patient who ends up with a pacemaker, but oftentimes they just kind of keep an eye on it. But then we have the third degree block. So if we talk about how the second degree blocks are sort of like a dating couple having an argument and like taking a break here and there between the P waves and the QRS, the third degree block they're divorced. Okay, there is no relationship between the P waves and the QRS. They are living separate lives. The atrial rate is doing one thing and the ventricular rate is doing another. Okay, so generally the ventricular rate will be between 40 and 60 if it's from the junction, which you'll see a little bit of a tighter QRS complex because it's going down the normal conduction pathway. If it's coming from a ventricular source, like any other, like Purkinje fibers or any other ventricular cell, it'll be a 20 to 40 rate from the ventricles. And the morphology will be a lot more bizarre. So right here, I would say that this would be a ventricular sourced QRS because it is kind of wide and bizarre. So if you see here, the P waves, there's one P wave right there. P waves will occur at regular intervals, okay? It's right here, if you look, it's like about 3 large boxes between each P wave, okay? And they're gonna chug right through, right? That's why you have one that's buried here. Meanwhile, your ventricular rate is also going to chug straight through, but at its own beat, okay? Sometimes it's hard to tell between a third degree and a type 2 because sometimes, usually it kind of gets confused with a second degree type 1, mostly because if it lines up just right, it might look like there's an association, but there's no relationship between the P waves and the QRS. Usually a longer strip will kind of confirm that for you. So if you have to print out a little bit more, it's not, then you need to do that. Similarly to the second degree blocks, the third degree block may or may not be symptomatic. Most of the time they are, because the ventricular rate is so slow. If it is a higher function from like the junction, or higher rate generated from the junction, then it might be a little closer to a normal heart rhythm, where like you won't necessarily see that level of bradycardia or decreased cardiac output, but the loss of that atrial kick, like that coordinated lub-dub, can actually really, affect cardiac output over a longer period of time. MI, right, is a common cause of a third degree heart block, so you should be super suspicious of an MI if you have any patient in a third degree. Beta blocker overdoses and calcium channel blockers are also strong causes of a third degree heart block. Electrolyte imbalances are also up there. Anything else that might block the AV node, so if you have a patient who's taking like any sort of parasympathetic drugs or parasympathetic stimulating drugs, they could also cause a third degree heart block, which is good, because if they stop taking the drugs, then they will stop having a third degree heart block and they won't need a pacemaker. So there's two different types of ventricular conduction disturbances. One is a bundle branch block and the other is pre-excitation syndrome. The one you're going to see probably the most is a bundle branch block. You need to perform a 12 lead to confirm a bundle branch block, okay? However, you can kind of tell when you first print out an EKG if there's a bundle branch block or not, okay? There is going to be an association between the P wave and the QRS for the most part. But you're going to have a really funky looking QRS, okay? It's not going to be that really cute, sexy, tight looking morphology complex. It's going to be wide and bizarre and kind of look like a PVC, but it's going to happen all of the time. So sometimes bundle branch blocks can just kind of be a normal variation, right? Usually that's the right bundle branch block. It's a normal variation that people may experience. Left bundle branch blocks are not considered to be a normal variation. Back a few years ago, if a patient presented with a new onset left bundle branch block, they were considered to be a STEMI note. You would have to call and get permission to bring the patient to a STEMI center. But there's a lot of different things that can cause it. Various cardiomyopathies or hypertrophy of the ventricles. MI, any sort of anterior MI, because now remember, if you remember the EKG setup that we had from the other day, the septum, right, the V1 and V2 is that left anterior descending. So that's a septal or anterior wall of the heart. If that's experiencing any ischemia or infarct, that's going to affect the electrical conduction system. So the kind of cool thing about the heart, and I'm going to draw a little picture because it's maybe a little easier to understand, is that you have these cells, and these cells are connected. There we go. So they kind of they all touch each other, obviously, right? They're muscle cells. So if you have an impulse, and it only affects this cell, this cell is going to slowly transmit that impulse to this one, and then again over to this one, until the entire heart is depolarized. The problem with that is it's very slow, as opposed to if you have all of these cells and they're being stimulated by this really fast pathway, right? Kind of think of it as this is the expressway, right? The Long Island Expressway. and this is taking the service road, right? And you have like traffic lights at each junction between the muscle cells. So here, this stimulus is going to take a very long time, comparatively, than if you were here stimulating each cell individually, okay? So it takes a little bit more time when that electrical system is not in place like it's supposed to be. So that's why you get that really wide, bizarre looking QRS complex, because it's going from cell to cell to cell and taking longer. So as it takes longer, it stretches that normally cute, tight QRS along the horizontal axis, which is time, okay? So as it stretches it a long time, it gets kind of funky and bizarre looking, and it gives us like an indication that the electricity is not conducting down its normal pathway. Now, we kind of remember, I think, hopefully from yesterday, that the normal QRS time is 0.12 seconds, right? That's 3 little boxes. When you start stretching it beyond 3 little boxes, then you are in the presence of a bundle branch block, but now you just need to determine if it's a left-sided or a right-sided bundle branch block. The right bundle branch block, you are going to look in, and for any bundle branch block, you're going to look in V1 and V6. The right bundle innervates the right side of the heart. Because the right side of the heart is a little bit less muscular, it makes a little bit of like a smaller kind of bunny ears, okay? As opposed to if the left bundle branch is not innervating the left ventricle appropriately, you get like a big, slurry, wide-looking QRS because it's just a larger muscle mass. It kind of just blurs everything out. Okay, and you'll get maybe like a little notch here. Those little notches are the difference between one ventricle depolarizing and the next ventricle depolarizing, if you want to kind of think of it like that. So what I usually say is if you're looking in V6 and you have an upright QRS with a drunk S wave, right? Your drunk S wave go home, it's usually a right bundle branch block. If you have an upright with like this kind of notched bunny ears, it's usually a left bundle branch. So let's see. Going into it a little bit more in depth. As the electricity runs down, it goes and it innervates the left ventricle the way it should, but all of these little cells need to be individually stimulated in the right ventricle, which is what generates this different, the up and down. As opposed to the left bundle branch where the right ventricle is innervated and the left bundle branch goes cell to cell to cell. Again, so you kind of lose a little bit of the coordination of the lub-dub, right? So if you have a significant discoordination between the two, it can really kind of screw with the way that the heart's functioning and can cause various hemodynamic instabilities. For the most part, it's not significant enough where people really notice, but if it is due to an MI or something, it can be significant. Another way to kind of indicate to determine if it's a left bundle branch block or a right bundle branch block is when you look in V1. If the QRS points up, and again, it's going to potentially be biphasic, so the largest part of the complex points up. Think of your turn signal in your car. If you flick it up, you're making a right-hand turn. If in V1 the majority of the QRS complex is pointing down, it's a left bundle branch block. For the most part, there is no real specific treatment for a bundle branch block. You just note it and carry on with your life. If you do have a patient who does have a new onset of left bundle branch and they're also experiencing chest pain or similar cardiac symptoms, you should evaluate them for Scarbosa criteria. Scarbosa criteria are right here. So if you're looking at the patient and you have, the first one is if you have a T wave. So in we talked about how the T wave always goes in the same direction as the QRS in a normal EKG. In the presence of a left bundle branch, that doesn't exist, okay? If you have a patient who has a left bundle branch, the QRS is going to go in one direction and the T wave goes in the complete opposite direction. So if you have a QRS complex and a T wave that goes in the same direction, commonly that's a sign that there's acute coronary syndrome going on, okay? Another criteria that you want to evaluate for is if there is a ST depression in leads V1 through V3. Remember, we talked about finding your J point. So like your J point would be here, your J point would be here, or your J point would be here. If you have an ST depression greater than 1 millimeter, you should have a higher suspicion for an MI. And if you have what you're expecting to see, where your QRS is going one way and your T wave is going another, but that J point is more than 5 millimeters above the isoelectric line, that's another indicator that there might be a cardiac event going on. You will not be tested on Scarbosa criteria. This is just something for you to kind of improve your overall knowledge of left bundle branch blocks. It's definitely something that you'll probably see some medics do in the field, but not a lot of medics are super familiar with this. It's just something to kind of, give you a leg up on knowing what you're looking at when you're looking at an EKG. Another thing that we usually see in terms of conduction issues is pre-excitation syndrome. Usually it's patients know that they have it. They'll usually diagnose and they'll tell you. But it's the most common one is Wolff-Parkinson-White. So there is an accessory pathway from the atrias to the ventricles that does not follow the traditional pathway. It bypasses the AV node. So in the presence of a rapid atrial rhythm, the AV node is usually the gatekeeper for the ventricles to make sure that you're able to maintain your blood pressure. The bundle of Kent, however, bypasses that and can transmit electricity to the ventricles or vice versa without any hindrance by the AV node. So it will cause the ventricles to depolarize earlier than usual. It will have this very kind of noticeable, it's called a delta wave, or it's another slur. It's kind of like the slurry kind of, you're a little drunk, right? So this QRS complex should be much more up and down, right? It should go to isoelectric line, then goes kind of straight up. Here it's like having a little too much fun with that tequila and just kind of swinging itself up into the QRS. That is, whatchamacallit, that's your indicator that there's an accessory pathway present. Most of the time patients deal with this without an issue. In the event that there is some sort of tachycardic event or AFib, then this can become deadly because it can cause the cardiac output to drop significantly. You do not treat this pharmacologically. This is a patient who would require synchronized cardioversion or just very rapid transport to the hospital because they need to be managed. Most of the time, these patients will have had an ablation. The problem with an ablation is not permanent. This usually does grow back within a few years. You also might see a patient who has no idea that they have Wolff-Parkinson-White, or WPW is an easier way of saying it. And when you do an EKG to evaluate them, because they're like, I have some palpitations or whatever, you notice this little delta wave, in which case you become the hero, as you hand it to the doctor, go, look at this. Again, because there is a accessory pathway, you might see that this ST segment changes because the entire flow of electricity in the heart has kind of been altered. So you might see some depressions depending on the patient's status. Other than the bundle of Kent, there's also a bundle of James and a Mahame fiber that can also be the source of accessory conduction. So the bundle of Kent goes right from the atrias to the the ventricles, so you get that delta wave. The bundle of James goes from the atria past the AV node, so it's going to not have that delta wave because it's still using that the normal pathway by which the electricity is supposed to travel. And then you have the Mahain fibers, which goes from the AV node directly into the ventricle, so you'll get a much wider, kind of more bizarre looking QRS, because it's going to start the cell to cell to cell process while this process is also occurring. For the most part, what you'll most likely see is going to be anything involving the bundle of Kent, and that delta wave is a little easier to pick out. So, how are we doing? You'd have to print it out, or you can change the. It depends. I mean, I've worked in some systems where they have lead 2, lead 3, and then like SPO2 on the bottom, right? So the LifePak gives you the 3 channels to look at. You can change that as you wish if you want to program it. Like if you're like, hey, I'm dealing with this patient who I suspect is having AFib, I'm going to turn V1 on, and like lead 2 and then V1. That's your choice. And a lot of departments will choose certain formats that work for them. And then depending on where you are, like if you work for transport, there's people who set up all different stuff how they want it. So most of the time, if you're going to evaluate it, I recommend printing it out, just because it's easier, and then you have a confirmation, and then you can hand it to the doctor and say, or the nurse, be like, here you go. But yeah. That's just the view. Yeah, I have to, let me see if I can pull it up real quick. Because it really, I thought it was in this presentation, and apparently it was not. Yeah, so you're starting here, and you're working your way around. So the view changes. So it's sort of like as you take it and it just kind of twists, and you're looking up at the other way. So like, this is my buddy Elvis. So if I was looking at Elvis from here, and then I started coming around here to his tushy, your view of his face is going to be different, right? So you're looking at it from here to like looking at it from here. So you're going to have that change, or that R wave progression. So let me pull up real quick. So see how here in V1 it's like a negative deflection, and then it becomes kind of biphasic, right? Because you're hitting that point where you can see it from both directions, and then it becomes primarily positive. That's your normal R wave progression. And whatchamacallit, we're going to go over this a little bit more in the next on Monday, maybe Monday. I think Monday's 12 leads. We'll go over it more when we do the 12 lead lecture, but just to kind of give you a general idea of like what it is that you're looking at, like that's kind of the way it goes. And if you look again, hold on, your normal layout for 2, 3, and AV, like your limb leads, it's positive, positive, negative, negative, positive, positive. That's your normal progression, like a normal view of what you should be seeing. I think this might be this right here. This is a fantastic kind kind of idea of what you should be expecting to see on a completely normal 12 lead, right? Your complexes are going to be positive in most leads. They're going to be negatively deflected in V1, V2, AVL, AVR, okay? And then biphasic in V3 and V4. So if you have any variation of it, that should kind of prompt you to look a little closer and, you know, do I have a conduction delay? Do I have a bundle branch block? Are my limb leads on properly? Because that's like the number one reason that you get like a funky looking EKG is that you were a little dyslexic that day and you screwed up your left and your right. Cannot tell you the number of times you do that. You print it out, you're like, damn it. And then you like start fixing it and the patient's like, what's going on? Like, nothing, it's wonderful. So those are like your troubleshooting kind of vibes. But yeah, if everything's in the right spot and it's kind of funky looking, that should prompt you to ask more questions. Dextrocardia, which is where the heart is mirrored and on the opposite side of the body, you have to also mirror your limb leads, and as well as your precordial leads, because the heart's on the opposite side. So if a patient does have that history, then they'll usually tell you, like, oh, you have to do it backwards. Like, okay, no problem. So, like, it'll be funky. Yep. I've had 3 separate patients who've had it, and I was like, that must be a EMS high. Dextrocardia, it's literally the mirroring of the heart. Sometimes it's also mirroring of all of the internal organs, depending on the level of whatchamacallit. So like your heart's on the right, your liver's on the right, your spleen, or your liver's on the right, your liver's on the left, your spleen's on the right. Like everything just flips, which is pretty wild. Yes. Yeah, because you have to fit it in. For the most part, because everything needs to fit. The problem with dextrocardia is they often also have a transposition of the great vessels. So when they were young, they've probably had surgery to fix that, because just because the heart was mirrored doesn't mean that the aorta was appropriately developed to the right, to the left side. Yes. Yes. Yeah. Exactly. It's treating your patient, not the monitor. Because you will 100% have a patient who is in a funky ass rhythm, and you're gonna be like, and the patient's sitting there like totally chilling. You're like, all right, let's go to the hospital. Like I can't do anything for you, because you're really, really good. Had a guy once who went through 8 different rhythms. He was a BLS job. BLS got it as a seizure in a deli. They went and picked him up, called for ALS for the backup. They're like, we don't know what's wrong with him, but he needs you. And I'm like, he probably needs a hospital, probably not us. He was diaphoretic, like a total hot mess. We get the 3 lead, get the 12 lead on, do the 12 lead. He has massive elevations in every single lead. And I was like, oh, that's not good. And then he turned his head to the side, started seizing, and I watched him on the monitor go from a sinus rhythm down to a bradycardia to asystole. We did CPR for about 10 seconds. He sat up, handed me his phone, said, call my boss, tell him I'm not coming in. And I said, sir, you need to lay down. You were just dead. And then he proceeded to go back into arrest 4 separate times with us, but moved through rhythms so quickly that we couldn't treat him. He was in sinus tachycardia, he was in SVT, VTach, went back to sinus rhythm, and then back into VTach. Before we could shock him, he went into asystole. We got him into the ER. We handed him over. We're like, I don't know what's going on. He's moving too quickly through things, and they're like, it's drugs. And I'm like, might not be drugs. I think his heart might actually just be imploding. He sat up again in the middle of CPR and went, call my wife and tell her I'm going to die. And then promptly coded again, and they never got him back. and he was like in his 40s. That was probably my most insane cardiac arrest that I've ever worked. BLS before ALS, exactly. That was pretty much the takeaway from that one, is just do what you know you can do. If you don't have a solution for it, then the most that you can do is just to do your best and transport to the hospital. Yeah. I did some more research on it, and there was a number of different things it could have been. It could have been a massive brain bleed, because apparently and I think we're going to cover this at some point in the 12 leads as well, brain bleeds can really screw with the cardiac rhythm. So if you have a patient who's totally AMS and like doing like the herniation breathing, you might have some really bizarre looking EKGs from that patient. Another option possibly was electrolytes. Another one was that it was drugs. And another one was like a dissection, like an aortic dissection. Yeah. No. I did try to follow up. I don't think they did an autopsy. So, or they did and they didn't have the information. Or they didn't want to share the information. It was Jamaica. So... yeah, Jody knows. You try to follow up on patient, it's like, good luck. You got to find a nurse who has got epic access and is really like nice to you. So, all right. So that's the conclusion of the first cardiac or cardiology lecture. Let me know how skills go on Wednesday. I'm sure it's going to be good because you'll be able to tie the information that we've just discussed and like practice it and kind of have a better idea of like what it is that you're looking at and like how things are working and sort of becoming more familiar with EKG tracings. If you have any questions, please let me know. Okay. I do not know. I know you have to wear business casual. So, and you're going to have to shave. Okay. Yeah, I don't believe they're ready. I know that he said maybe a couple days ago they were being sent to be embroidered, so you'll probably have them relatively soon. EKGs, 3 leads. Just 3 leads, yeah. 12 leads is going to be, I believe, next week, because we have to do that lecture, because that's another big chunk of information that we're going to discuss. A little less chunky than this one, but still chunky. Sure. Yeah, sorry, Jolly Volley Fire guys who think khaki shorts are the appropriate wear for all items or for all events. Cannot do so. So I will leave you with this note. Next time that you're at the firehouse, I want you to look at how many white dudes have calf tattoos. There's a direct relation between white dudes, calf tattoos, and their involvement in a Jolly Volley department. It's about 80%. My husband has a calf tattoo as a Jolly Volley fireman, so I'm allowed. Yeah, what do you have on your calf, Zach? Let's see it. So, little food for thought. As I said, if you have any questions, please let me know. I will try to clarify things as best as possible. I know it's a lot of information that we just discussed, but it will get easier, and I am glad that you will be able to do some practice with the EKGs because it will help. If you do look at the resources on the classroom, there are a number of, there's a Khan Academy one, and there's an EKG stat, I think, is a game that helps you kind of recognize different EKG rhythms, so that maybe you'll go in with a little clarity. And it's actually pretty fun. So, all right. What? Resources. Module 4 resources. There's a bunch of links. There's a bunch of videos. And the PowerPoints are also there. So, all right. If there's no further questions, I will say it.